everybody's back, yes? Give me the nod, Krishna.
Yeah, everyone is here.
Okay, lovely. Right,
Yeah.
well then, in that case, I'm going to say a huge thank you to Natalie, because I know she's had a really difficult and stressful morning. So just the fact that she's here is amazing. So thank you so much, Natalie. I didn't doubt you for 1 minute, because I know you so well, but I know that others may have had slight panics, but not as great as yours, I don't think. But anyway, let me introduce Natalie with no more ado. So Dr. Natalie Shenker, she's a UKRI Future Leaders Fellow at Imperial College London. So UKRI is UK Research and Innovation. So it's a combination of Innovate UK with various research councils. So very hugely important and influential in terms of funding in the UK. And her fellowship focuses on the public health impacts of human milk banking, which we talked about a little bit earlier, and the complexity of human milk composition. So Natalie is a medical doctor, was a pediatric surgeon by training, before undertaking a PhD in epigenetic risk biomarkers, at which point her life changed fundamentally for ever. And more recently, partly as a result of her PhD, she was, together with myself, I'm very honored to say, the co-founder of the Human Milk Foundation, which is a charity that supports research, education, and access to donor human milk. So at the center of this work, the Hearts Milk Bank, which was established in 2017, is now the largest non-profit milk bank in the UK. It provides screened donor human milk to babies in hospital, currently around 40 different hospitals in the south and the east of London, but also fundamentally different in the UK. It provides screened donor milk to babies whose own mothers need a little bit of extra time and support in establishing full breastfeeding, or where breastfeeding is impossible, either at home or in hospital. And Natalie will tell you much more about that. The title of her presentation, as you can see, is COVID-19 Vaccination and Breastfeeding Challenges and Opportunities, but actually she's going to talk much more widely, I think, about human milk banking as well during the COVID-19 pandemic. So over to you, Natalie, and we'll look forward to asking you some questions later. If you have questions, everybody, please post them in the chat so we can collect them. Thank you.
Brilliant. Thank you, Gillian. And gosh, the last 5 years has been quite busy, and I would say the last month has been probably even worse than ever. And the last 24 hours has just capped it all off. So I'm incredibly apologetic for being late today, and really looking forward to sharing a little bit of the process that we've been through in the last year, navigating our milk bank through the COVID-19 pandemic, but also helping to support other milk banks in the UK and globally, and really learning from what was happening from a range of different experiences across Europe, India, every country that has a milk bank. And thank you very much, Gillian, for that very kind introduction. So I just want to start with this graph. This was taken from the Johns Hopkins Coronavirus Resource Centre a couple of weeks ago now, but really demonstrates just the staggering scale of this pandemic that we're living through. But I remember seeing this graph back in late February 2020. A month before that, I'd had a meeting with Gillian and our microbiology expert advisor at the Hearts Milk Bank. The meeting was actually about something completely different. And at the end of it, I just said, Jim, what's happening with this virus in China? And he said, well, I don't really know, but I think we should probably be a bit worried. Now, Dr. Jim Gray is an absolute world authority and one of the calmest people I've ever met. And to hear him say, I think we should be a bit worried, kicked me and Gillian and the entire Hearts Milk Bank team into action. Now, the reason it did is from history. Now, I didn't know about milk banking before I met Gillian. That was a completely accidental and very happy serendipitous event in my life. But it is surprising that I didn't know about human milk banking, because I'd trained as a paediatric surgeon. I'd worked at several hospitals that either had milk banks or access to donor milk, and I'd worked many a long night on paediatric intensive care units and neonatal intensive care units where donor milk was being used, but I hadn't absorbed it through my medical training or my experience that was important. Nutrition, as a rule in the UK, isn't taught very well to doctors as a whole. But what I learned by setting the Hearts Milk Bank up is that in the 1960s and 70s, milk banking in the UK was a relatively ubiquitous service, and that there were milk banks of some form or a capacity to get babies access to human milk in almost every UK hospital delivering babies. And what put a stop to that was a virus, largely. Not the coronavirus, but in the 1980s, the discovery that HIV could be transmitted through breast milk, and the research that showed that HIV was rendered neutralized, was made safe by pasteurization, heat treatment of the milk, took a long time to come out, several years, by which time most milk banks had to close due to a lack of funding for the equipment, but also for the time and the staff needed to be able to support mothers through being screened. And so this picture on the left of the virus eating the world is not coronavirus. That's a picture from Time magazine in the 1980s. But by 1991 in the UK, only 6 milk banks remained. And the service has been splintered and underfunded, under-resourced ever since. So we knew when Jim said he was a bit worried that an infectious pathogen could be the greatest threat to human milk banking that we were faced. And I'd like to take you back a little bit to explain why that was such a particular concern. So just to run through quickly my slightly unusual career, I started out life as a surgeon. I trained at Oxford and then went into paediatric surgery, and then took time out to do a master's in developmental biology at Imperial. And it was during that process I became utterly fascinated with epigenetics and the concept that really early life exposures, even those in utero, could help pattern a disease, the risk or the protection from serious diseases throughout a child's entire life. And that's really what I was most interested in, is making significant change that could help protect babies for a lifetime. During that time, I became a mum and tried to donate my milk to our local milk bank, which was run by Gillian. And it was just during that conversation that I had the very happy realization that the cells in milk could be used to answer some of the questions in my PhD. Now, over the next 2 years, I used to visit Gillian most Fridays to pick up samples of milk, and became fascinated with her experience and really trying to understand what milk banking was and why it wasn't well known or better resourced. At the end of 2015, Gillian retired. I say retired, she's by far the busiest person I know. And really a lot of that has been the global work that she's been doing ever since. But her retirement meant that the milk bank she'd run for nearly 30 years was going to close. And so what happened after that is I had a very unusual postdoctoral period whereby I left medicine, I left academic training, and I set about, along with Gillian and a huge team, setting up the Hearts Milk Bank. And then won my fellowship in 2019 to try and put some evidence around everything we were doing. Now, why on earth did I take that leap in 2016? Well, it was because I'd started to think differently about what human milk was. Milk evolved from our earliest forebears, our earliest ancestors in the mammalian structural evolutionary structure. It is the only reproductive strategy that's shared by every mammal in the world, whether they lay eggs like duckbill platypuses, whether they carry their young in pouches like marsupials, or whether they have placentas to nurture infants during pregnancy. Placentas only developed about 50 million years ago evolutionarily, but lactation predates that by a good couple of 100 million years. That means it's probably quite important. And indeed, as I was reading all these papers, I was learning that milk wasn't nutrition, it wasn't about calories, it was about developmental regulation, epigenetic regulation, development of the immune system, development of the brain. And so I started making lists of what was in it, very simply, and met up with some wonderful people who took those lists and made them into really stunning images. that spark conversation. But if you just look over on the right-hand side, if I blow it up a bit, then you can see how many molecules are there in the fatty acids and how many antimicrobial factors. And the key importance of the fatty acids is that they're largely there to help structure the mammalian brain, this very specialized organ that makes us quite different from other primates, helps us to communicate as a species. And human mothers are exceptionally good at extracting fatty acids from diet through the blood into the milk in a way that most other mammals can't do. I was finding other things like the smallest molecules, tryptophan, an amino acid, apparently helps babies to sleep. Babies aren't born with a normal 24-hour diurnal rhythm. And tryptophan is found in higher levels in the evening than during the morning. And it's one of the mechanisms, along with cortisol and other hormones, that help to pattern that very early diurnal system that helps babies differentiate between night and day. And milk contains stem cells, really interesting stem cells that could be used therapeutically. They could be involved in regeneration of the infant body because studies have shown that they're taken up into every organ system. And yet we don't know why. Is that an accident of evolution, or do they serve a purpose? And there's so much untapped research potential in human milk. Now, one of the side effects of the pandemic is that my research team largely had to work at home. So Sophie Wedekind, my fantastic research technician, spent 6 months looking into all of the antiviral properties of human milk. And we thought it would be largely based about antibodies, secretory IgA, oligosaccharides, lysozyme, and lactoferrin. And indeed, there's a fair bit of literature about each of these. But when she started looking, she started to find papers, a couple of papers for each component, and then the research would fizzle out, showing that vitamin A, oxysterols, lactoferrin, cytokines, extracellular vesicles, bacteriophages. And then things started to get a bit silly because there's literally scores of different mechanisms with hundreds of different bioactive molecules that have developed alongside immune protection for the immunocompromised baby that are in human milk. And most of these have not been researched adequately. The other thing that made me pause and think that something needed to change was that infant feeding is very much underpinning a new model of health, a new paradigm. We've known for decades that each of us is born with the genetic susceptibility to disease, to any disease, but it's our environment that helps govern that risk of whether we'll actually develop it and how old we'll be when we do. That's things like eating a poor diet or becoming obese or smoking or drinking or just being stressed, anything that happens in our environment. But over the last 10 years, the concept of an aberrant microbiome, a microbiome that isn't functioning well, that is made up of different bacteria, fungi, viruses that our body has evolved to expect, we've found that that has been a trigger towards accelerating stress on the body. And recent studies have suggested that infant feeding could be a mechanism by which the gut microbiome becomes different. We don't know whether that's going to be pathological, but it's different, and that's interesting. I'm going to leave it just there because the research is developing, and I don't rush to conclusions before there's good evidence. But there is burgeoning evidence in a number of fields which are quite surprising. The child study in Canada has shown that infants exposed to even small amounts of formula in the first few weeks are at a greater risk of asthma and severe asthma compared to those babies who are exclusively breastfed. That obesity rates and overweight rates are higher in infants in a dose-dependent way. The more formula they get, the more chance they have of being overweight, these children. And then diseases that haven't previously had a lifestyle factor, if you can call it a lifestyle factor, such as type 1 diabetes mellitus, an autoimmune disease. Acute lymphoblastic leukemia, the commonest leukemia of children, has been linked to aberrant microbiota development. And could it be underpinning neurological disease? When I talk about over a life course, could the development of the brain, the functional differences and mechanistic differences between breastfed and formula-fed infants make a change to the resilience of that brain over a life course. So what on earth is milk banking going to achieve in all of this? Well, just to take you back a step, for those of you who don't know what a milk bank is, they operate in a similar manner to the blood transfusion service, whereby donors who have extra milk to their own baby's needs, either at home or in hospital, are screened, and they undergo a series of health questionnaires and serology screening for infectious diseases that can be transmitted through milk. The milk at our milk bank is collected frozen and transported, where it is heat treated, pasteurized at the milk bank according to standardized conditions, and stored until tests confirm that microbiologically it is safe to be issued. Hospitals are always prioritized, but surplus from the Hearts Milk Bank is sent into the community. We've sent nearly 10,000 litres of donor milk out to hospitals and the community in the last 3.5 years. And the reason we prioritise hospitals is that for vulnerable babies, having access to human milk can be life-saving. Principally, that's revolved around the evidence collected in the last 30 years of a reduced risk of necrotizing enterocolitis, a devastating gut condition that has a high mortality rate of between 40 to 50%. But working with Gillian, I've learnt over the last 8 years that it's not all about neck, that these babies also have reduced risks of other complications of prematurity, and so on. They have reduced duration of stay, but critically, the mothers can be better supported to establish their own feeding. So why did this service not already exist in the UK? Well, it's in large part because we have cultural barriers to understanding what human milk is. The fact that I, as a doctor, had no idea about any of this tells you all you need to know, really. But we did some formal surveys and asked the general population in the UK whether there was a biological difference between breast milk and formula, and 67% said no. Then we asked whether being formula fed had any long-term consequences for health, and even more, 72% said no. So we came up with a model that if we could provide a milk bank that enabled equitable access to donor milk, that there would be a assured supply, so clinicians could counsel parents that there would be donor milk available if it was needed, then we could facilitate trials, research, and drive change. And with Gillian's support, that's what we're doing. Things were rocky to begin with, but once we established the charity and started to really talk about what we did, it started to change. We were named in 2018 as one of the UK's 50 new radical organisations changing UK society for good, moved to the Rothamsted Institute just north of London, which gives fantastic facilities and transport links, back in 2018, and were awarded a Points of Light award by Theresa May as a prime ministerial honour for volunteer. And what we do now is always prioritise donor milk for sick babies, but where we can, we support donor milk into families in the community, always free at the point of need to parents, but funded by either commissioning groups, rarely, but mostly by charity. Alongside that, we're really evaluating every aspect of this: psychological health for the parents, maternal breastfeeding rates, infant outcomes, trial-based studies, whatever we can do. And trying to reach out as much as we can to learn from other milk banks, and also to advocate on milk banking's behalf. And more about that in a little bit. And try to drive education, because that's really going to be the thing that changes the system most of all. So working with doctor groups, the GP Infant Feeding Network, the Hospital Infant Feeding Network, the Breastfeeding for Doctors group, which offers peer support to medics who have terrible breastfeeding rates. But we're trying to make change to thousands of doctors, which will then change practice. And alongside that, laying evidence for a national milk bank service by the collaborative work leveraged through my UKRI funding to really look at milk in very different ways and come up with perhaps ways that we can use milk more cleverly as a personalised therapy. And so COVID was likely to put a stop, or could have put a stop to all of this. So I hope you can understand why February and March were such a period of intense activity. Now, during that time, we geared up in the Hearts Milk Bank, looking at every aspect of our milk bank operation, whether it was getting our team in, being able to recruit donors, getting blood tests done when all of the primary care services that normally did that shut down. Supplies, could we make sure that the sterile containers could come in, that every other aspect? Could we even get, printing materials, because without a printer, the whole milk bank grinds to a halt. And it's such a fragile service that, as we've seen with every aspect of life, when there's a vulnerability, COVID has really stretched it to the max. But by the end of February, we were feeling confident-ish that we were going to be okay, that we'd prepared everything. And that's when we started working with all of the other NHS milk banks in the UK to make sure that they would be in the same position as well. And that was largely because we started to be called by hospitals saying that they couldn't get donor milk from their local services because they'd had to have staff diverted to other operations in the hospital, or simply put into furlough because they were at high risk of COVID-19 itself. But critically, what also happened is, because of the work in the UK, Gillian came up with the idea of initiating a similar support network on WhatsApp with all of her contacts collected over the previous 30 years. And this was the start of Gamba. So March the 16th, 2020 was the day that Gillian set up the WhatsApp group. And within 2 weeks, there were 80 members from 35 countries. There's now over 120 from over 40 countries. And this has been an absolute godsend for the strengthening of milk bank services, because we've been able to share evidence, we've been able to ask and answer questions and collate data as quickly as possible. It hasn't waited years to work out whether pasteurization made coronavirus rendered it safe. We had the answer within weeks. And we could also do some theoretical work around the fact that breast tissue effectively chops up coronavirus before it's even put into milk, even gets into milk. So we could start informing rapid reviews and overturning the maternal separation policies that have been so damaging globally. Alongside that, we were publishing lots of things, and Gamba really kicked off a drive to publish a call to action to basically start waving a flag that this was a vulnerable service that was being severely affected in multiple areas. In Canada, the ferry that used to take donor milk out to the islands stopped. In India, the staff couldn't get in because there was an embargo on getting onto public transport. And all across the world, things were happening that were affecting milk banking services. So by July, we started to take a breath and set up some more thoughtful preliminary work, keep writing about the relationship between human milk and COVID-19, and informing national guidelines. And then this paper came out from colleagues at the WHO, highlighting just the absolute tragedy of maternal separation. And it modelled that if mothers with COVID-19 had been allowed to stay with their infants, even if they'd tested positive, then globally around 1,800 to 2,500 babies would have died, which is a tragedy. But by instituting maternal separation policies, which interrupts breastfeeding and most likely stops breastfeeding being successful, then estimated that between 188,000 and 273,000 infants have died, over and above what would have been expected. And that is the most sobering statistic I think I've ever read, because it is entirely avoidable and would have been avoidable if there'd been a greater voice of scientists largely who understood how milk worked. And then vaccination came along, and on the 2nd of December in the UK, the first anti-COVID vaccination, the Pfizer-BioNTech vaccine was licensed and contraindicated for pregnant and lactating women out of an abundance of caution. These women were not included in trials, and the animal studies hadn't been done, and nobody was willing to talk through a pragmatic approach that enabled women to choose. And I thought it would be useful to share, just for 2 minutes, the story of Gemma Partridge, who's actually a trustee at the Human Milk Foundation, but she's a consultant obstetrician up in Norfolk, where she runs the clinical services for sick mothers during pregnancy. And she's also mum to Wilf, who was preterm and became a milk donor, and that's how she came across our charity. But basically what happened in the UK is that when the Pfizer-BioNTech vaccine was licensed, the messaging around that highlighted that there was uncertainty about safety. And that meant that if you were breastfeeding, you should wait until you'd finished breastfeeding and then have the vaccine. If you were breastfeeding when you had the first dose, you're advised not to have the second dose until you finish breastfeeding. Now, the problem is this put people into a completely unsustainable fashion. They were largely at this stage in December and January frontline healthcare practitioners who were in direct contact with COVID, terrified about taking the disease home to their families and faced with an impossible choice. Should they lie about breastfeeding, remain unvaccinated, or stop breastfeeding altogether? So lying about breastfeeding for a clinician undermines personal values, the duty of probity and being honest. And the fact that there was no data collection really didn't enable any informed decision making to be made and potentially could put professional registration under threat. For women who chose to remain unvaccinated, well, they were putting themselves at risk, potentially risking their own patients and potentially impacting their ability to even work. Or they could stop breastfeeding. But then for all of the reasons you know too well and everything I've just explained, they're risking their own health, their own mental health, and the risk to infant health as well. And this was just an absolute disaster for these thousands of women across the National Health Services and the knock-on impacts of that decision to countries such as India that adopted a similar regulatory stance. So doctors work in frameworks where they should be empowering patients to make their own decisions based on the evidence available, the value structure that they have, their own preferences and beliefs around health informed by evidence. And this wasn't being allowed to happen. Women weren't being given the choice. And at this stage, Gemma said it felt like not only a medical and epidemiological concern, but a human rights issue. So together with a team of medic scientists and advocates, we managed to get the decision overturned by the end of December. Gemma was vaccinated and doubly vaccinated by the middle of March. So the evidence that we do have is that vaccination generally during lactation is overwhelmingly safe, but evidence generally is also scarce. There has only been one phase 1 clinical safety trial on any vaccine ever. Mostly, the vaccine safety data is collected through yellow card reporting systems or national surveillance structures. To date, and this is perhaps slightly out of date because I think there's been more data now, but there's certainly no evidence of vaccine transfer for any of the vaccines tested, and 3 papers published that have shown strong antibody responses transferable through milk in up to 100% of vaccinated individuals in the largest study. And from national registries and surveillance, of which I've been taking part in the UK, there's no evidence of significant ill effects in mother or child. Some mums do notice a reduction in lactation, probably because they're feeling a bit poorly after the vaccine and not feeding as often. And there have been 1 or 2 cases of mastitis, which it probably would be helpful to tell mums to keep making sure that they express regularly or they feed as regularly as normal. And there's now strong support from the Academy of Breastfeeding Medicine in the States, the CDC, and the Royal College in the UK that vaccination is safe in lactation. So lastly, what could we have done better? Well, it would have been really, really easy to establish safety in the earliest days by doing a simple trial. And I know this would have been easy because we had the ethics approval to do this work. And we also had 500 volunteers who contacted us through Facebook, desperate to get somebody to check what was happening. We had all of the tools set up, but there was absolutely no engagement from manufacturers. And I think from a regulatory point of view, it's critical that regulators are enforcing some sort of trial onus on manufacturers before the release of any new vaccination or medication from the point of view of lactation. So my hope is that for the future, if clinicians, scientists, the general public can understand lactation and not assume that pregnancy is just shorthand for lactation, they're two completely separate processes. If we can include trials with lactating women, then we can enable proper risk counselling that allows women to make the choice through stopping breastfeeding if that is her choice, but understanding that there are risks to that as well. Working with key stakeholders, particularly in government communications, to improve communications and strengthening the multi-collaborator networks globally through GAMBA, through the other networks that we're part of, so that the next time this happens, and unfortunately there will be a next time, we can save even more time and more lives by acting early. So I'd welcome any questions, but just like to thank the enormous team of people. They won't all fit on one slide now, but you all know who you are, and my contact details are there if you'd like to follow up on anything I've said. Thank you.
Thank you, Natalie. As always, that was an absolutely superb presentation. And once you, we'll leave that on the screen for a minute so that anybody can take a photograph of it or write it down. And then when you stop sharing your screen, we can start checking if there are any questions for you. I'm sure there are. I'm sure that there are questions that people are thinking of, but maybe whilst we're waiting for those or waiting for anyone else to speak, maybe I can ask you a question. And